pancreatic cancer in most patients. Only less than 2% of the patients are diagnosed in stage 1. And even if we see a cancer which looks radiologically operable, this is usually not an early stage cancer. And I would like to draw your attention to this very interesting paper. And I think and I hope that in the future we'll see more and more patients with early stage cancer. And if this happens, I won't have to talk about challenges of radiological staging. Okay. CT is the best validated imaging modality for staging of pancreatic cancer. It is an accurate test for predicting resectability and even more accurate for predicting unresectability. The technique is very important. We need good quality multi-phase post-contrast acquisition with thin section imaging and post-processing. I work in a tertiary hospital, so the majority or a large proportion of the scans we review at MDT actually performed in other hospitals on different scanners. And the quality of those scans do not always meet these quality criteria. And I think it is then the radiologist's responsibility to decide that the preparation for the MDT, whether the scan is suitable for accurate staging or not. And I think if it is not, the scan should be repeated. As per guidelines, MRI is a very useful problem-solving tool in primary staging. The strength of MRI is the excellent contrast resolution. We can usually delineate tumors much better than on CT, and we can also detect CT isodense lesions. In this case, CT showed mild biliary dilatation with abrupt termination of the CBD in the head of pancreas, but we could not pick up pancreatic duct dilatation or any pancreatic mass lesions. On MRCP or MRI, we can clearly demonstrate that both ducts are missing in the head of pancreas, and on T1 and diffusion weighted imaging, we can see a small solid mass in the head of pancreas. And in this presentation, I will show you a lot of MRI scans. This is not because MRI is in our routine staging protocol, but because many patients, as part of their investigation for obstructive jaundice, get MRCP. And in many hospitals, T1 weighted and diffusion weighted images are part of the MRCP protocol. And these images are perfect for demonstration of solid pancreatic masses. If we give contrast, we can assess vascular invasion accurately on MRI. On this slide, you can see the same tumor on CT and MRI. This is a locally unresectable tumor invading the SMV and its branches. And the features on MRI and CT, as you can see, are basically or very, very similar. So in patients who cannot get CT contrast, we can do local staging with MRI. MRI liver is part of the primary staging in many hospitals in Europe, because previous studies showed that it is possible to pick up CT undetectable liver metastasis with liver MRI. Although this practice is not recommended by evidence-based guidelines at the moment, but there are ongoing trials. One of them is the DIAPANC study. And so we have to wait for the result of those trials. Anyway, when I worked in Glasgow many years ago, we started using MRI liver in the primary staging in patients who had, or when CT suggested potentially curable disease. And this is our very first patient, and this patient had a borderline resectable cancer. And MRI liver showed this solitary 3 millimeter metastasis in the left lobe, which was too small to biopsy. So we did a follow-up scan a month later, and you can see that the lesion is now bigger. And the first CT scan, which demonstrated the same lesion, was performed 3 months later. PET-CT is usually a problem-solving tool in primary staging. The exception is the UK. The NICE guideline was updated in February 2018 based on the results of the UK multi-center study. So now we offer PET-CT to patients with localized disease on CT who will be having cancer treatment. Questions have been raised about this practice. Nevertheless, that is our protocol at the moment, and this is a PET-CT which picked up para-aortic lymph node metastasis in this patient with a relatively small head of pancreas cancer. We use the terms resectable, unresectable, and borderline resectable disease in our everyday practice, but the definitions of these categories are not simple at all. So this is an NCCN guideline from 2017, and this was slightly modified in 2019. And the definition of resectable disease is relatively simple and straightforward, but the rest of the table is rather busy and complex, suggesting that the definition of borderline resectability and unresectability are not straightforward at all. Added to this, and as demonstrated in this nice paper, the inter-observer agreement is moderate at best. So I think the only way how we can overcome these difficulties if we have a very close collaboration in our local HPB team to have a very good understanding of the local resectability criteria. As surgeons perform venous resection routinely in most hospitals, now it is the radiologist's job to report the degree and extent of venous involvement accurately. It can be of note, it can be difficult to differentiate desmoplastic reaction from true vascular invasion. I think the large number of classifications of venous invasions suggest that that assessment of vascular or venous involvement is not an easy task. Okay, our job is further complicated by the complexity of the peripancreatic venous anatomy and the large number of variations. However, if we have a good quality scan, CT scan, it is possible to identify all major branches of the SMV on CT. So let me show you a case. This patient had a pancreatic head tumor. With the help of MRI, it is probably easier to delineate the tumor on CT, which is in contact with the SMV and the Henle trunk. And as demonstrated on this slightly unusual projection, we can clearly visualize all the major vessels of the SMV. I do not have any experience with arterial resection, so I won't talk about this in detail. It might be beneficial in highly selected patients to achieve R0 resection, and radiology obviously has an important role in pre-surgical planning. There are a few highly specific signs of vascular invasion on cross-sectional imaging: vessel embedment in tumor and venous obliteration, vessel encasement, as you can see here, vessel wall irregularity and vessel caliber stenosis, tumor thrombus in vessel, although it is rarely seen in pancreatic cancer, and the so-called teardrop SMV sign. Template reporting has been found useful in a number of cancers, and I think pancreatic cancer is not an exception. I was a member of a working group of surgeons, oncologists, and radiologists, and we created this cancer reporting template. On this slide, you can see the final version of the template, which is hopefully now used in all HPB centers in the UK. Of note, it is also possible to demonstrate extrapancreatic neural invasion on CT scan. This has no impact on patient management, but might be a predictor of poor prognosis in resectable and borderline resectable tumors. So this is our first case, resectable cancer in the head of pancreas. So the question is, how do we get to this diagnosis? So the first step is detection and delineation of the tumor. You can see that in this patient, there is a double duct dilatation, and the delineation of the tumor is not very difficult in this case because the tumor is hypodense and relatively well demarcated, as seen on these CT images. So the next step is the assessment of relationship between tumor and vessels. And due to the nonlinear course of peripancreatic vessels, we need multiplanar reconstructions in multiple planes. And if we have an appropriate plane, we can clearly demonstrate a clear fat plane between in this plane between the head of pancreas and the SMV. Our second case is an unresectable cancer in the neck of pancreas. So again, if we have appropriate MPR reconstruction, we can assess the degree and extent of venous involvement, also encasement of the celiac trunk and the common hepatic artery. In this case, there is single duct dilatation with distal CBD stricture. The mass is nearly isodense. Probably with the help of MRI, we can say that this small hyperattenuating lesion actually represents the tumor where the dilated duct stops. Nevertheless, there is clear fat plane between the head of pancreas and the SMV. And MRI is reassuring because we can clearly identify this very small tumor in the head of pancreas surrounded by normal pancreatic parenchyma. This case is a bit, sorry, this is not a complicated case again. So there is double duct dilatation, and the mass in the head of pancreas is isodense, but there is, in this patient, there is quite a large amount of fat around the peripancreatic vessels. So demonstration of clear fat plane between the presumed pancreatic mass and the SMV and other vessels is not very difficult. This tumor was also in contact with a short section of the GDA, but this was far from its origin. So we can make the diagnosis of resectable pancreatic cancer. This case is a bit more complicated. There is again single duct dilatation, no obvious mass in the head of pancreas. But this is a patient who has very little fat around the peripancreatic vessels. Basically, the pancreatic parenchyma is in contact with the SMV and also with the SMA. In this case, it helps that the normal caliber pancreatic duct is seen between the stricture and the vessels. And again, MRI can help because there is very normal parenchyma in this region. So again, this tumor can be categorized as a resectable tumor in the head of pancreas. Local staging of cancers in the distal pancreas is usually less challenging, but there is a case for demonstration. So this tumor invades the splenic parenchyma, extends into the perirenal space, not surprisingly, encases the splenic vessels. And we raise the concern that this tumor actually extends toward the stomach along these short gastric veins. And indeed, in this case, resection of the gastric wall was necessary during surgery. If the tumor is big and involves multiple vessels, the diagnosis of unresectable disease is not very complicated. So, such in this case, so this is a big tumor encasing long section of the SMV, including the tributaries, and also abuts the SMA or long contact with the SMA and encases its mesenteric branches. This is one of those suboptimal scans, but still it is possible to make the diagnosis of unresectable tumor in the head of pancreas. You can see that the tumor abuts the SMV over approximately 3 centimeters in length. Again, very close to the origin of the mesenteric branches, and also abutment of the SMA is evident down to the level of the first jejunal branch with short section encasement, as you can see on this image. This was a shocking diagnosis in this 35-year-old patient who was very fit, but you can clearly see that with appropriate reconstructions, we can demonstrate a long section encasement of the SMV level with near occlusion of the lumen to the level of the tributaries, and also the tumor was in contact with the SMA. And also long section contact between the tumor and the replaced right hepatic artery is demonstrated on this staging CT scan. At this stage of investigations, we hope that maybe this tumor will have a very good response to chemotherapy and can be or would be potentially operable. So we did a full staging, but unfortunately, the MRI liver showed a small solitary metastasis in the left lobe, which is vaguely seen on PET-CT as well. Okay, the diagnosis of borderline resectability can be even more challenging. So let me show you potential borderline resectable pancreatic cancer at the junction of the neck and body. Again, this is one of those slightly suboptimal scan, but I think we still can make this diagnosis confidently. So the tumor is in contact with the splenoportal confluence and splenic vein over approximately 2 centimeters with contour deformity. And also we can demonstrate the same contour deformity over a short section of the SMV. And despite the suboptimal quality of the scan, clear fat plane can be demonstrated with the SMA. I think we sometimes our decision at MDT is biased by unfortunate circumstances. So this small operable tumor was not picked up at the time of first presentation. It was very small. So it was diagnosed 6 months later when the patient became mildly jaundiced. So if we, strictly speaking, this is a borderline resectable tumor. So there is a tumor abutment involving, or the tumor is in contact with the portal vein and SMV over approximately 2 centimeters, but there is evidence of contour irregularity. Probably you can see it on this image better, but it is obvious also on this reconstruction. And finally, at the MDT, we decided upfront surgery, firstly because the patient was only mildly jaundiced. Secondly, probably because there was a pressure on us by this misdiagnosis. So upfront surgery was decided, and unfortunately, this was an R1 resection. Okay, this is the reason why we categorize this tumor borderline, because you can see the tumor here. It is in contact with the portal vein and SMV, but no contour deformity was demonstrated. However, the tumor encases long section of the GDA to the level of its origin, and there was solid tumor contact with the left hepatic artery. Okay, as part of the staging, it is also very important to assess the peripancreatic vasculature prior to surgery. So this patient has locally resectable periampullary tumor, probably potentially cholangiocarcinoma. And this staging CT scan shows replaced right hepatic artery, also tight stenosis near occlusion at the origin of the celiac trunk. There is possibly the left hepatic artery fails from the dilated GDA, and there is extensive arterial collateralization around the head of pancreas. So it's not my job for today to talk about the rationale for neoadjuvant chemo or chemoradiotherapy, but I would like to mention a few potential benefits. It might increase R0 resection, convert unresectable to resectable disease, select patients with better biology, better compliance than with adjuvant therapy, and reduce micrometastatic disease. However, evaluation of therapy response on CT is rather challenging. Many previous studies or many studies show that CT underestimates response and resectability post-chemo or chemoradiotherapy. So surgical exploration should be considered in all patients without signs of disease progression. And I think a robust discussion at MDT is required in all these cases. So now I will show you a few cases with good therapy response and a few cases with stable, or 2 cases with stable disease and various outcomes. Okay, so this patient is a very fit patient. The primary staging showed multivascular involvement, but there was a very good response. So you can see that the tumor, the bulk of the tumor has significantly decreased. The shape and caliber of the portal vein and SMV returned to normal on the post-therapy scan. So there was a long abutment of the SMA on the staging scan, or the primary staging scan, and the tumor along the SMA, or the bulk of the tumor, has significantly decreased. But unfortunately, what we saw here is that at this point, the tumor appears to have progressed, and now there is near encasement of the SMA at this level. So basically, the consensus decision at MDT was no exploration as persistent and possibly progressive SMA involvement. In this case, again, multi-vessel involvement on baseline CT and very good response. So you can see that the tumor became much, much smaller, and contact between the tumor and the portal vein and tumor between the GDA and the common hepatic artery has significantly improved. So the consensus was to take the patient to theater, but unfortunately it was found inoperable on surgery. This is again, very good therapy response. Tumor became significantly smaller. The contact between the tumor and SMA is no longer apparent on the post-therapy scan. And again, this patient was taken to theater, and unfortunately, a small metastatic deposit was found on the liver. And again, a very good therapy response, very small residual tumor, contour deformity almost disappeared, and this was a T1N0R0 resection. Okay, now I will show you 2 almost identical cases. Both patients had stable disease on chemotherapy, but the outcome was very different. So this is I had a pancreas tumor with focal irregularity and potential involvement of the portal vein and SMV, and you can see that basically there is no significant difference between the pre and post therapy scan, and it was an R0 resection, and on pathology very small residual tumor tissue was found. And if I show you this case, it looks very, very similar, and again no significant change between the 2 scans, and unfortunately this was an R1 resection and very little or no pathological response on the surgical specimen, and this patient had local recurrence 4 months later. And we all know that pancreatic cancer can progress rapidly. So this is a case to demonstrate that. So at the time of presentation, this patient had a 1 centimeter tumor in the head of pancreas causing single duct dilatation. So a fast-track Whipple was planned in this case, but this was at the peak of the pandemic, so it was very difficult to find a theater appointment. So the patient became jaundiced and was stented, but still upfront surgery was planned. But before that, we did a repeat CT scan, basically 1 month later, and we could see that actually this tumor has significantly increased and there is no new pancreatic duct dilatation. So we repeated the staging, and the liver MRI showed multiple small liver metastases. So I'm now at I hope I kept the time, and so it is nearly end of my presentation. So this is usually the time when speaker takes question, but before that, I would like to ask you a question. So the question is, what type of surgery would you perform in this case? And I will show you 2 sets of images. Both, so this is the first set of images, which is a staging CT scan, which shows this peripancreatic collection secondary to duct disruption. And I can tell you that on subsequent imaging, this collection has significantly decreased in size, but there remained quite extensive post-inflammatory stranding or fibrosis or post-inflammatory reaction between the stomach and the tail of pancreas. So the tumor is here. This is a 2 centimeter tumor. It causes contour irregularity over approximately 2 centimeter section of this planoportal confluence and the SMV. And if I say that this tumor, the patient underwent neoadjuvant chemotherapy, and if I say that this tumor remained exactly as stable, my question is, what type of surgery would you do? It is not a very tricky question. It's just because I would like to show you a set of images which I wonder whether it would change or have an impact on your surgical planning. So what would you plan?
Yeah. So this is Chris Wilking. At the very least, I mean, it looks like he's going to need a Whipple operation.
Yeah.
You know, it's a little unclear if that is a pseudocyst related to proximal obstruction or, you know, or if it's like a second primary lesion, like, you know, like this developed in IPMN. I don't know. So I'd want to investigate the tail a little bit more before I would decide. You know, I guess at the end of the day, if we weren't clear, it would be a total.
Okay, so actually, I think, yeah, that is the cyst was as part of the EUS, so had an EUS confirmation of adenocarcinoma from the tumor at the junction of the neck and body. And it seems, based on fluid analysis, they seem to be a simple pseudocyst or post-inflammatory collection in the head, and it basically disappeared at a later stage. Only quite an extensive fibrosis remained between the stomach and the pancreas. But I show you the second set of images, which shows a few vascular changes. These were all revealed by the staging scan. So the patient had a severe celiac axis stenosis, which at a later stage was stented. Also had a 1.5 centimeter aneurysm arising from the replaced right hepatic artery. At the time of stenting, it was coiled. And as an anatomical variation, which is a bit unusual, but still we were quite convinced that both the IMV and the middle colic vein arise from the splenic vein, very, very close to each other, and approximately 1.5 centimeter from the splenoportal confluence. So with this change anything, or do you think it makes your planning or surgery quite complicated? Or you would just go ahead with your original plan?
Well, I mean, to be clear, that the patient has a biopsy adenocarcinoma in the neck of the pancreas, right?
Yes.
So it doesn't necessarily change my operation. Still not clear about what's going on in the tail of the pancreas. You know, you need to be able to deal with the vascular stuff, but patients still would need a whip.
Yeah, that's fine. I think we decided the patient has not been operated yet. This is a case from last week, I think, or from 2 weeks before. I mean, it is just more about if this patient probably need a venous resection. And I think if you potentially, I don't know how to mobilize the vessels, potentially, whether this patient, if this needs dissection of the splenic vein, or I think it is just an interesting case to think about, just how potentially you face a number of difficulties in these cases during surgery. There might be quite extensive fibrosis from this previous duct disruption, all these changes related to the vessel replaced left hepatic or right hepatic artery. So I think sometimes all this planning is rather challenging. So as to summarize, I think close collaboration in the HPB team with constant feedback is very important. And I think pro forma reporting can help. Thank you very much.
Thank you, Heidi. That's a great overview of imaging for pancreatic cancer. I think we'll carry on with the talks and we'll do the questions at the end, if that's all right with everyone. So Chris Wadsworth, are you online? Chris?
Yes, I'm here. Sorry, I'm just going to share my screen. Sorry, Adam.
Okay, no problem.
Here we are.
So if everyone just save up their questions for Heidi in the chat box or piece of paper, whatever you want to do, and we'll carry on.
So good evening. Can you hear me okay, Adam, before I start? Good.
Yep.
Okay, so thanks very much indeed for asking me to speak this evening about endoscopic ultrasound. And I was given quite a broad title, which I have tried to encompass, and I will try and squeeze it in 20 minutes. So I'm a HPB gastroenterologist at Hammersmith Hospital, which is part of Imperial College in London. And I'm going to present about EUS in the diagnosis and management of pancreatic cancer. And I've also been asked to touch on cystic lesions, though I'm doing them a bit of a disservice towards the end of my talk. Apologies for the colour scheme on this. It was suggested by my PowerPoint, and I thought it was a contrast to the black and white pictures I'm presenting, but it's a bit garish, and I'm sorry about that. So I was going to work out how to. Right. So endoscopic ultrasound in the UK, and I'm sorry if I'm a bit UK centric for the international audience this evening, but in the last census, which is a while ago now, over 10 years, there were 65 centres in the UK that performed EUS. And predominantly having linear EUS equipment as opposed to radial EUS equipment, which has been the trend over the last 10 years in the US towards more linear approaches. The advantages of that are that it is particularly useful in imaging the HPB axis compared to radial, and it also allows you to do FNA with the same instrument that you're doing your diagnostic EUS with. So the trend is increasingly towards linear practice, although there are some units who very successfully image the HPB axis with radial endoscopes and then switch to a linear scope, sometimes called the FNA scope in the unit, if they need to put a needle in a lesion. And there were around 100 EUS endoscopists in the UK, and it's probably increased slightly since then. It's still a preponderance of gastroenterologists, with contribution from radiologists and surgeons. I think that since 2011, the proportion of gastroenterologists has increased slightly the proportion of radiologists undertaking EUS has dropped a bit, and the surgical contribution is probably about stable. But that, as I said, data is 10 years old. I know I'm not talking to an audience mainly of EUSs, and I apologise to people who do EUS in the audience. But just to give a little bit of background and a bit of update, this obviously is an ultrasound machine. It's very similar to the ultrasound machines it's the same as the ultrasound machines that radiologists use, but with different modules. The linear scope's pictured bottom right of this screen, and it just demonstrates the fact we're able to use an operating channel to deliver an FNA needle, as well as, and I'll touch on it later, other accessories for therapy. I'll go through this quickly, but it is important. EUS factors patient factors in EUS. You'll see on the left, that's a typical patient. We do these procedures, unfortunately, in a lot of units in the UK, predominantly under conscious sedation. We don't have anaesthetic support. So we're using midazolam and fentanyl to do 30 to 45-minute procedures on patients. And this does cause limitations to what we can achieve. And it's really important that when we're preparing patients, briefing patients on what to expect from an EUS when they're referred for it, that they understand what the procedure involves, and also to select patients correctly. We continue in our service to have patients arriving from around our region, in their early 90s with major comorbidity, kyphotic, cardiorespiratory disease, and clearly not fit for EUS. And it's not the same as an EUS. It's not the same as a CT scan. So it's just an opportunistic reminder of that. We're doing this with conscious sedation. Sorry. The other patient factor that's really important is, particularly in suspected pancreatic cancer, is patients need to arrive knowing why they've come for the test. We have a lot of patients that arrive in our service who've, for instance, been admitted with a fall to the trauma unit in our local trauma centre. Someone's drawing on my screen, which is a bit distracting. Who've had a trauma scan in the local trauma centre, which has incidentally found a likely pancreatic cancer. And the first thing they hear is our appointments office ringing them to recall them for an EUS. And the first chat we have with them before we can consent them for their EUS is explaining to them that they've got a likely pancreatic cancer on their recent CT scan. So it's really important when the patient arrives, they know why the procedure's been requested. It's appropriate to them, it's going to make a difference to their management, and that they understand what the potential underlying diagnosis is. Another thing that I've just put this picture in the middle to illustrate, and I've done this myself, is patients arriving to have EUSs who've had bariatric surgery or previous gastric resections with gastric bypass, and we're being asked to assess the head of pancreas. And that's really very, very hard in patients who've had gastric bypass. So just making sure there's not a surgical history that precludes us accessing the target is important. And the final thing which constantly delays patients' pathways in a lot of services is patients arriving for their EUS still anticoagulated. So if we are planning to do an FNA, it's really important that any anticoagulation could have been stopped. And there's some really useful guidelines recently published at the end of last year by the BSG with a really straightforward flow chart. This is painful, sorry about this. So the risks of EUS, discomfort during the procedure, bleeding, perforation, pancreatitis, which some people aren't aware of, 1 in 300 of the FNAs we cause pancreatitis, and sadly we've got a patient on our ITU 6 weeks into an admission with an acute severe pancreatitis after an FNA. So it does happen rarely and can be very serious. I'll skip to the final point on here, tumour seeding, which people are concerned about. When we're FNAing lesions in the head of pancreas, this is less of an issue because if curative surgery is subsequently undertaken, the track of the FNA will be resected with the tumour. That's not obviously the case for tumours we access from the stomach in the neck, body and tail. And so we need to be really careful when thinking about referring patients for FNA of potentially resectable lesions in the neck, body and tail. When we do in the US, we take a systematic approach, and there are multiple stations that we go through to fully assess the HPB axis. This picture sadly doesn't show imaging of the body and tail of the pancreas, but station 2, by rotating the scope, we would image the body and tail of the pancreas here. I'm not going to overburden people with EUS anatomy tutorials, because it's really tricky for people that aren't used to looking at EUS or ultrasound. We're all fairly comfortable looking at CTs and orientating ourselves on CTs, but this just illustrates some of the structures that we can see, and essentially we are able to access pretty much with the entirety of the pancreas and the adjacent vascular structures. The proviso to that is, as soon as there is a very substantial tumour or substantial lymphadenopathy and vascular complications, the anatomy does become hugely more complex. And as opposed to a CT scan where a radiologist can talk us through exactly what the effect of that mass is, if that mass is pushing some of your structures out of your field of view, it becomes very, very hard to orientate within the anatomy. So I won't labour this slide, as everyone knows this, but essentially the process of assessing patients with new diagnosis pancreatic cancer ranges from initial clinical presentation through CT, MRI, PET-CT, EUS where required, and ERCP or PTC where required, with sampling if it's indicated. We've obviously had a very clear explanation of how good CT and MRI are at diagnosing pancreatic cancer. And I think that historically there have been discussions about the relative sort of sensitivity and specificity comparing these different modalities. But I think that essentially CT and MRI in some units has become the dominant initial imaging modality for diagnosing pancreatic cancer. And of course, a significant number of patients can proceed direct to surgery on the basis of those scans. But what can EUS add? Well, to rattle through these, EUS guided FNA has got very, very good sensitivity and very, very good specificity for pancreatic cancer. And this obviously feeds into the fact that it can be useful in determining the exact nature of lesions that are indeterminate on CT and MR. We're able to biopsy lesions that are too small to be characterized by CT or MRI. We've recently diagnosed a patient with a 5mm adenocarcinoma in the body of pancreas that was a whiff of something on a CT scan, but on a EUS we've been able to secure the diagnosis, and they've had successful resective surgery. We're able to biopsy lesions that are encased by surrounding structures that make percutaneous biopsy difficult or impossible. We can definitively characterize possible malignant lymph nodes within the regions we can access. We can biopsy suspected metastases of the left lobe of the liver, and ascites is even very early ascites is very, very easy to see on the EUS and very, very easy to sample. So it's possible when we do see early ascites, we often do put a needle in to try and secure further staging information or diagnostic information in that way. We do have other ancillary technology that we can now use with EUS, SonoView, which is microbubble contrast, which is given intravenously, which allows us to get a better idea of the vascularity of lesions. Adenocarcinoma of the pancreas being enhancing extremely poorly with microbubble contrast, things like neuroendocrine tumours lighting up like a Christmas tree, and inflammatory nodules in acute and chronic pancreatitis somewhere in the middle with significant enhancement. We can do elastography to get an idea of tissue stiffness, which allows us, particularly in patients with background pancreatic disease like chronic pancreatitis or recent acute pancreatitis, to see stiff areas within the abnormal pancreas and target those for FNA, as those are more likely to be malignant. EUS can deliver confocal laser microscopy into cysts and forceps biopsy into cysts. But I'll return to that a little bit later in my talk. EUS FMB is a newer technology. We've switched from FNA needles to the FMB needles, which the picture was in my opening slide. And these achieve much better volumes of tissue, which the histopathologists and the oncologists appreciate from molecular analysis. I think in terms of practicalities, the timing of EUS is really important. It should be after CT and an MRI if it's felt necessary to do an MRI scan, but it should be before any ERCP or PTC is attempted if possible. The reason for this is we don't want to mess up the CT staging by looking at something, putting a needle in it and causing local inflammation that affects the CT scan. Nor do we want to do an ERCP first, cause some localized inflammation or mild pancreatitis, and then do an EUS that is not able to adequately stage the tumour. So the sequence of cross-sectional imaging with CT and or MRI, followed by the EUS, followed by the ERCP, in our service and our practice is really important. And we're trying to move to a full anaesthetic delivered sedation service in our HPB endoscopy practice, so that we can offer patients an hour and a half long slots where they come, we do their EUS, we proceed to the ERCP if that fits with their treatment pathway, and we do the whole thing in one sitting with one propofol sedated set of procedures. And this is to improve the patient experience and to expedite their diagnosis and management. So here's a few pictures that I don't know if anyone knows how I can get rid of the lines on my presentation that we'll put on, but I'll just keep talking about the slides. I'm sorry if it disrupts anyone's.
Yeah, sorry, I didn't know where they came from.
Sorry about that.
But anyway, I think you get the gist of it, and most people look at EUS pictures and wonder what the hell's going on. So on the left-hand side, these are all pancreatic adenocarcinomas, and you can see that it's the dark blacker tissue in the center, forming a mass with an ill-defined edge that's infiltrative. Normally, as I say, these do not enhance with microbubble contrast, and often you see these disappearing into the back of your field of view when they're very, very large. On the left here, I'm just showing a few of the other sort of diagnostic modalities we have. On the left side of the screen, you can see an FNA needle, which is coming from behind the transducer, and it's the white line that you can see coming from about 1 o'clock tangentially across into the lesion. And as I've already alluded to, you can get these needles into something that is 4 or 5 millimeters across for FNA, and anything a centimeter or more, you can normally get core tissues for histology. So even very small lesions, we can normally get samples from. In the middle is showing you a contrast enhanced EUS with microbubble, and you see the lack of enhancement in the lesion in the middle. And on the right is a elastography picture. So there are paired pictures, and you can see on the right hand side of that third image the dark hypoechoic lesion that's labeled tumour. And then if you look at the colour sort of array on the left hand side of that image, you can see where that hypoechoic area is blue, and blue indicates very stiff area. So this is where the lesion is. So what are the indications for EUS FNA in the diagnosis, EUS with or without FNA in the diagnosis of pancreatic cancer? So I think it's reasonable to assert that if resectability is uncertain because of tumour or patient factors, then it's reasonable to undertake an EUS to inform the further staging of the tumour, and also to gain histological confirmation, because if the stakes are very high, then obviously the patient and the surgeon may wish to have definitive histological confirmation of the diagnosis. If the patient's not fit for surgery but is fit for palliative chemotherapy, it's still in almost all units, I think, mandated that you have histological or cytological confirmation of the tumour. And certainly if neoadjuvant chemotherapy is indicated, then having histological confirmation is required. Atypical presentation or atypical imaging is important. 35-year-old patients do sometimes get pancreatic cancer, sadly, but if someone's got something that looks like a pancreatic cancer and they're 35, it's probably important that they have, I think it is important that they have an EUS to further assess that lesion and histologically demonstrate it, because the differential is wider than simply pancreatic adenocarcinoma, and we don't want to miss autoimmune disease like IgG4 pancreatopathy, We have a steady trickle of TB that does mimic mass-forming lesions in the pancreas. Lymphoma, NET, obviously is more typically characterizable on the cross-section imaging, but there are still a lot of indications for histological confirmation of mass lesions in the pancreas. In acute or chronic pancreatitis, EUS is a nightmare, a bit like trying to pick a cancer out in a CT or MRI in someone with acute or chronic pancreatitis. But if there is an area of concern on a CT or MRI, in conjunction, close collaboration with our radiologists, we can EUS that area, target that area, and do FNA cores from that area to try and prove one way or the other whether there is a superadded adenocarcinoma. There are studies out there that demonstrate very good performance of EUS in indeterminate lesions on CT and MRI scan, and I won't dwell on the numbers there for the sake of time. There are a small group of patients who have negative CT or MRI but do have symptoms. They have got serological evidence that is of concern. We get a steady trickle of patients who for some reason had a CA99 checked and it's 1500 and there's nothing seen on any of the imaging where any EUS is appropriate. It's a shame, but sometimes we have to do it. And there are certainly indications in family history, very strong family history of pancreatic cancer, where EUS is often included as part of the screening or surveillance program. And I've put on the end here surgeon or patient choice. We do sometimes have patients that come through our MDT who, when they're told we think this is almost certainly a cancer, we're going to give you a Whipple. This is what a Whipple involves. We'll say, look, I don't want a 5%, a 3%, whatever the percent risk is that this isn't cancer, and you're going to put me through this. And in those situations, via our MDT, we would certainly undertake an EUS if that was required. So just briefly, I'll touch on the NICE guidelines. As usual, these are quite broad, but they do recommend that EUS is used if the MDT is required it requires it with EUS guided tissue sampling. I'll skip through these slides for the purposes of time, but EUS remains within the NICE guidance, but is certainly not mandatory before patients proceed to surgery with resectable clear-cut adenocarcinoma of the pancreas. In patients with high risk of pancreatic cancer with familial risk, as I said, EUS is there and it's within the NICE guidance. It's not recommended for use in patients with hereditary pancreatitis because of the background disease and the fact that the calcification and distortion of the normal pancreatic anatomy makes EUS extremely difficult, and the idea of picking out an early lesion would be very, very hard. So it's not offered to patients who've got hereditary PRSS1 mutations, but in other patients with Lynch syndrome and other strong genetic risk factors for pancreatic cancer, it can form part of their surveillance program. So we've talked a lot about EUS staging of pancreatic cancer, and I'm not going to present all the data that sort of puts EUS up against MRI and PET and CTs. I'm not sure it's hugely useful in our current practices. But over the years, the relative performance of EUS, again, when you put it up against CT, MR, has changed, and it's changed in favour of CT and MRI scan. And it's likely this is due to improved technology within the scanning systems, as well as changes in the TNM staging that we're sort of judging against. And it's probably now an unhelpful comparison anyway. I think EUS has got its niche, but clearly CT and MRI are first line in staging of pancreatic adenocarcinoma. EUS stages small volume disease better and tends to correctly upstage vascular involvement rather than downstage lesions, though that's obviously a gross generalization. And of course, we've already alluded to the fact that FNA EUS can definitively define positive lymph nodes. So again, NICE include EUS as an optional extra in the staging of pancreatic cancer. It's by no means mandated, but obviously has an important role. So I'm going to move briefly through an update for those of you who aren't sort of EUS enthusiasts, just to give you an idea of what's going on in EUS guided therapy. And this is quite exciting for us as gastroenterologists and EUSs, surgical EUSs as well, and radiologists, in that I'm sure all of you will be aware about the contribution that EUS guided cystgastrostomies offer in patients with walled-off necrosis and complex cystic lesions in the management of acute pancreatitis. But in the management of pancreatic cancer, very well established is the use of EUS-delivered celiac axis neurolysis, celiac neurolysis in patients with pain, and there's ongoing discussion about the timing of that and whether we do it in enough patients. In the management of obstructive jaundice, there's now well-established or becoming well-established roles for EUS-delivered EUS-delivered stents, transduodenally or transgastrically into the biliary tree to decompress obstruction in patients who are being palliated where ERCP fails. And there are now some enthusiasts arguing that we may see the back of ERCP in palliating malignant obstruction of the bile duct. But we're still some way off that. Management of gastric outflow obstruction, this is gaining traction and appears to be useful. So this is where, and the next slide will use this as to illustrate what an Axios stent is and how we use them. But this is where we establish a fistulous tract between the stomach and a loop of jejunum to bypass proximal jejunal duodenal obstruction. And then finally, the use of EUS to ablate tumours. So probably the most established, though it's rarely used in the UK to my knowledge, is the use of EUS to place fiducials for radiotherapy to pancreatic lesions. But now there are a couple of devices on the market which allow EUS RFA ablation, which is being studied of tumours. And then EUS brachytherapy, which is available, certainly not NICE approved, and this is the injection of beta-emitting particles into pancreatic cancers via EUS as a local form of brachytherapy in palliation. So just to illustrate what an Axios stent is, it's deployed on the left-hand side. It's obviously constrained on the delivery catheter when it's inserted, but under EUS guidance, there's a tip on there that with diathermy cuts through whatever you press it against effectively, and you can, under EUS guidance, deploy it into cysts or into adjacent structures, and then deploy the stent, which has got a dumbbell shape, to establish a tract. And this slide just illustrates it's the same principle for whether you're putting this between the stomach and the gallbladder or the duodenum and the bile duct, or is the same principle that applies, as you can see. So in an EUS gastrojejunostomy, you would normally firstly place a catheter through the stricture over a wire, pump water into the jejunum to distend it, and then with your EUS scope, you can then clearly see that jejunal loop. You puncture it, deploy the inner flange of the stent, retract it, so there's tension in it, deploy the second flange of the stent within the stomach, and that opposes the jejunum with the gastric wall and creates a tract, which these go up to, I think, 2.5 centimeters. And we've only done a couple of these in our centre, but there are higher volume units around the UK, around the world, and I think in the UK where this is finding a niche. By no means am I advocating this as sort of the primary management of patients with as being proven to be that should be the primary management of patients with gastric outflow obstruction, but it is a useful tool in a select number of patients and may establish a more substantial role. And this is just a few pictures to illustrate it. So you can see the stent in the bottom pictures being ballooned up just to make sure it's fully deployed and embedded, and then it's peering through that stent at some jejunal mucosa. So I'm conscious it's gone 8 o'clock, so I'm just going to rattle through the section on EUS assessment of cysts. So EUS offers a huge amount of extra information about cysts. We're able to identify very subtle features of concern that are sometimes not visible on CT or MRI. So solid elements to the cystic lesion, nodules within the cyst, and subtle main pancreatic duct dilatation or involvement in cysts. We can use sonoview to further assess particularly solid nodules. Some centres we don't use confocal laser microscopy to actually inspect the inside of cysts, and you can get tiny forceps. You can actually biopsy the epithelial lining of cysts. More typically, we undertake FNA sampling for cytology, CEA, glucose, and molecular and in research settings in some centres, molecular markers. And again, EUS is included as part of the algorithm in the NICE guidance in the diagnosis and management of cysts. Just a few pictures. The top left picture is a mucinous cystic lesion with, you can see the black anechoic cyst, but there's a very significant solid nodule here, which is highly concerning, and this proved to have transformed and be a malignant lesion. Over here is a typical IPMN, side branch IPMN. And in this lower picture, you can see another IPMN, which is communicating with the dorsal pancreatic duct. So that's a cystic lesion communicating with the dorsal pancreatic duct. This is a main pancreatic duct, which is grossly distended, and you can see, I think you see it's not anechoic, there's mucin within it. And if you look further up the tail of this pancreas, you can see nodules within the epithelial lining of that cyst, which enhance with sonoview. And that's a major feature of concern, as is the gross distension of this this main pancreatic duct. So this is a main duct IPMN. And I'm just going to finish up because I'm an endoscopist with not an ultrasound picture, but this is a endoscopic picture from the patient illustrated in those previous EUS pictures. And this is a beautiful example of a fisheye appearance of the papilla with a distended papillary orifice with mucin extruding from it, and I'm sure I can convince you it looks a bit like a fisheye. So in summary, I hope that I've at least touched upon the importance of sequencing the EUS within the protocol of other investigations in the diagnosis and staging of pancreatic cancer, and the EUS is complementary to the other investigations. Obviously, where EUS fits into the algorithm depends on local availability of equipment and expertise, and also the timeliness of access. If you've got rapid access to a test, it's much more appropriate to use it than if it's going to delay a patient's management. I hope I emphasised the importance of patient selection and preparation and making sure that EUS is the right test for the right patient. There is certainly a role before surgery in the diagnosis of pancreatic cancer where the presentation or CT appearances are not clear cut. There's certainly a role for it in histological confirmation where chemo or radiotherapy is being considered. It's useful in the screening or surveillance of patients with some forms of hereditary risk for pancreatic cancer. I didn't get to talk about it in the body of my talk, but I think one of the interesting things that's emerging is the potential circulating markers, particularly tumour DNA, and whether this will form a sort of liquid biopsy that might replace or certainly replace some of the role of EUS. And I think we await that with interest because there certainly seems to be some exciting developments. I'm sorry I had to go through them so quickly, but I hope I've just given some of the non-EUSs in the audience an idea of some of the therapeutic options that are emerging with EUS. And I think, you know, I was very cynical about these when enthusiasts first started touting around, but there's now very promising data emerging about safety, effectiveness and durability of some of these techniques, and certainly in palliation of some of these complications of pancreatic cancer. I'm sure that they will become standard of care in some applications. I think that in the UK, we've still got some way to go in planning our EUS services. Capacity, technology, expertise and anaesthetic support is important. We need to get our training sorted out. And I would again, like the previous speaker, emphasise the importance of locally agreed networks, pathways and protocols so that we know what we're doing with our patients and we do it in a timely way, and we're not taking patients through the NDT 4 or 5 times. So working effectively through NDTs, but along well-agreed and established and evidence-based protocols. So thank you, and I apologise for rushing some of my talk.
Thank you very much, Chris. It was a great talk. Overview of EUS for pancreatic lesions, pancreatic cancer. Chris, Wolfgang, and Sharon, do you want to have any comments or questions for Chris Wadsworth?
Yeah, well, first of all, thanks, Adam, for the invitation. It's a great honor to be here. Both talks were excellent. I learned a lot, and you know, I really appreciate being included. I know there's a lot of questions in the chat room, but I could ask 100 questions, but I'm going to ask two quickly. I want to get in. One for Hedvig is, you had mentioned about selection of tumor biology and neoadjuvant, and I think that's very interesting. And I was just wondering your experience on using PET scan for the primary, pre and post neoadjuvant to correlate with treatment response. Do you use that? Are you aware of any literature in the radiology where there's a correlation to that? So not so much anatomic resectability, but biological resectability. And then for Chris, we just had a case this morning where we were looking at on EUS a solid component within a pancreatic cyst, and it's the same argument over and over. Is this a mucin ball, or is this a true solid component? If you could comment on some tricks that you do that can differentiate between those two. And once again, thanks, Adam, and excellent talk to both.
Okay, thank you. I try to answer the PET-CT question. So it is very interesting that I think it is only the UK in the world which uses PET-CT routinely in for the primary staging of pancreatic cancer. And it's even more interesting that we do not use this opportunity to assess the cancer response post-chemotherapy, because it is not recommended at the moment by the NICE guideline to assess response. So basically, from my experience, I cannot talk any our experience, because we use it only in the primary staging, and we do not assess response routinely with PET-CT. On the other hand, literature suggests that it is possible, although the data, because I think the problem is that as many units do not use it routinely, that is why it is very difficult to get robust data on response. So I think there are small cohorts or relatively small cohort studies suggesting that PET-CT is theoretically a great tool to assess therapy response, but there are also MRI, and I think MRI is very promising. So there are a number of studies on especially to assess early responders, so not necessarily at the very end of the chemotherapy, but also after 2 cycles, to select patients who are good responders to chemotherapy and not very good responders. So there are possibilities in MRI, not necessarily the routine sequences what we use for diagnosis, but advanced sequences can be potentially used in the future, I think. So I hope that we will have all these technologies and that bit more data about these.
That's interesting to know, and you brought up a good point about understanding early on if you're failing. Actually, you presented a lot of typical cases where a patient started with neoadjuvant and progressed to metastatic disease, and at that point they go to unresectable. And so we have no real good measures of in early on in treatment, are they responding or not? We only find out after we fail. So that's interesting about the MRI.
This is where we need biomarkers, Chris. Yeah.
You and I got to get out of the OR and get to work on that.
Yeah, definitely.
Yeah, I'd probably just add a point to that, to the floor, and I don't want to labour any discussion about this, but I suspect the problem with uptake of PET in the primary diagnosis and workup of cancer is also a component of the false positives that you can get from PET. It's something that we don't want to look for. We don't want to be hit with that problem, because it just delays our surgery, which we want to get on with, and we know that we need to get moving quickly with these patients. So the false positive problem is probably the primary reason we don't necessarily use it routinely in our unit. Yeah. And I suspect that's probably slowed the uptake somewhat.
Yeah, good point. Good point.
And there's a question about the mucin ball.
So the mucin ball, so I don't know whether SonoView is available in the US, but microbubble interrogation of that with contrast harmonics would be really useful, because mucin balls definitely don't enhance, and dysplastic nodules usually do. So if it enhances on sonoview, even modestly, then that is a nodule in the back of that lesion or in the side of that lesion, and of concern. And then of course the other, default answer of any EUSer is stick a needle in it, if in doubt. So those would be my two approaches to it.
Are the microbubbles something that is that only sort of used in expert hands, or is that something that is now becoming generalizable where the typical endoscopist can use that? Or
So
is that a pretty specialized thing?
I think if you're in a big tertiary HPB center doing EUS, then it depends on case volumes. It's definitely not a long learning curve. It's a short learning curve. If someone's decent at linear EUS, normally they need to spend a bit of time with a radiologist that does microbubble, transabdominal microbubble ultrasound, because you learn about the basic principles of it, but it's not technically demanding.
Great, thank you.
No, I'd agree with that completely. It's something as a radiologist I do pretty routinely, and it's not rocket science. Useful addition. I'd add to the technique there to distinguish mucin balls from true nodules. One, mucin balls tend to be nice and regular, and they tend to have a hypoechoic center, whereas a solid nodule will be uniform all the way through. So it has a different look to it. Secondly, yeah, the argument to, if you're in doubt, put a needle in it, absolutely. And I sometimes find when you've got the needle in it, if you can puncture the mucin or nodule itself and then wiggle your elevator or big wheel, if it moves around in the cyst, you can detach it from the wall sometimes, which is always reassuring as well.
Thank you.
We've got a question in the chat box actually from Nida Amini, the rising star in surgical oncology. Do we have data regarding the patency of EUS gastrojejunostomy compared to the surgical gastrojejunostomy?
No, is the short answer to that. And I hope I acknowledged, I sort of tried to acknowledge that in a rush towards the end of my talk. I wasn't trying to present this as a panacea. So these are cases, these are cases that are done in circumstances, for instance, where duodenal stenting is proven impossible or has failed, where the patient's not a candidate for a surgical gastro-jej. And we've been looking for cases to do selectively via our MDT in a, I hope, critical and governance-focused way, and it's taken us several years to find a couple. So it's not prime time yet. And in fact, of those techniques that I presented, it's probably the one that is least established. I think the others are further down that pathway to generating some useful data on effectiveness and well, safety, certainly effectiveness as well, and durability. But I think that, yeah, these aren't this is not a technique that's going to replace surgical gastrojejunostomy as palliation in patients who are reasonably fit and have got a lengthy prognosis. I don't think it will.
There's another comment actually from Iman. He says, then gastrojejunostomy or gastrojejunostomy can be a treatment for SMA syndrome using EUS. What about that? SMA syndrome,
yeah,
by EUS.
Yeah, I mean, I think that we might be a little way off taking that cohort on, but it's a very interesting point. It's not one I thought about. I mean, we're using the Axios in benign disease. We're using it in patient. The acronym is EDGE, where patients who've had gastric bypass, we're actually using, and then subsequently develop, because someone left their gallbladder behind, they subsequently develop choledocholethiasis. And previously we would have to go do a joint procedure with a laparoscopic access of the isolated stomach, and then do a standard ERCP in theatres with the assistance of the laparoscopic surgeon. With EDGE, we're able now to do a puncture through from the non-isolated gastric remnant through into the isolated stomach, fill it with water, do an Axios stent into that, place the ERCP scope down through the remnant stomach into the duodenum and do a standard ERCP. And then we take it out we put the stat, we take this, we normally put it in a couple of weeks before, then we go back and do the RCP, then we take it out, and we're looking at whether using the Apollo suturing device then close the defects useful or necessary. It's not really clear whether you need to. A lot of centres don't bother closing the hole; it just closes of its own accord. But I know I didn't answer the question there, but I just wanted to allude to a different sort of benign application with these devices.
That's amazing, actually. Okay. Anyone else have any questions in the audience, or Chris, Wolfgang, Sharon, do you have any other questions or comments?
I've got one just for Heidi. Excellent talk again. Thank you very much. Really insightful, and I think it covered every topic I could think of within it to teach. I want to take you back to the start. The concept of MRI for resectable disease in pancreatic cancer. I think you said that you perform that for all patients. Okay.
No, what I said that interestingly, we quite often have the MRI images because a patient gets MRCP as part of their that is just the routine for obstructive jaundice, and because in our region most of the MRI protocol in most hospitals, the MRI protocol contains the T1 and the diffusion weighted images. These are just excellent for detection of the tumor. So it is not in our protocol, but many of our patients have these images, which can help especially to delineate the tumor. And with the help of MRI, we can be more specific with CT scan, but it is not not in the routine protocol. But still, I really like it. And if there is any question, especially if we had a patient recently, I could not really identify the tumor very well, but there were questions about close proximity to vessels, and we did an MRI, and on that, although the relationship between the pancreas and the vessels could be better clarified on CT because we gave large amount of contrast and there was no movement artifact, but the combination of the two techniques helped with local staging. So sometimes we do it, but not routinely.
So do you think that NICE guidance will develop and evolve to include it more or less?
I think what major change I'm expecting is about the use of MRI liver routinely. I think in Europe, a number of centers, despite it is not recommended by, as I mentioned, by evidence-based guidelines, but it seems that based on the literature data, in 10 to 15% of the patients, MRI liver upstage the disease because it picks up very small liver lesions. And it's interesting because if we have this in the primary staging, it makes no big difference if the pancreas is covered by a liver MRI. So maybe we get a bonus with that. So I don't think that I'm not expecting that. So that is the big change I'm expecting in the future, that maybe MRI liver will be included in the primary staging.
What happens in the States, Chris, Wolfgang? Do you get a lot of EUS or MRI liver preoperatively? No? Fair enough. And everyone gets a CA19-9, presumably?
Yeah, sorry about that. Was trying to find my mute. Yeah, it's, the use of MRI in staging of pancreas is if we have a questionable liver lesion on CT scan. Obviously, MRI is better than CT for assessing that, but it's only in select cases. Yeah, everybody gets a CA19-9, and as we discussed when we were together recently, we often will make a decision for neoadjuvant based on that number, even if it is a technically resectable no vessel involvement lesion.
If I can have a comment to Sharon, just to add something. So however, we now have a PET CT, and I totally agree that the questions are about the false positive. So quite a number of cases we have to further investigate other findings. Last time a patient had a hotspot in the mouth and such things. So that is a problem with PET-CT. But if it is widely expected that MRI liver can help with the primary staging, then we'll have too many modalities. So PET-CT, MRI, I think it is, we have to be very pragmatic. So I don't know what the future brings, but it is, yeah, so it is, can be quite complex.
It is, but I think I think it's going to be ultimately a combination of things. The thing about a PET-CT is that it's not so much anatomic, but physiologic, functional, and that's sort of what we want to know. As you know, probably better than anyone, a lot of these tumors really don't change very much on imaging. They look the same. So we really don't have feedback on whether or not we're having any kind of treatment response just based on anatomy. And so it's a physiologic measure. The other thing that, and I can't remember who brought it up, is where things are heading are going to be liquid biopsy. And that's not going to be to replace imaging. It's going to be as an adjunct, as a composite marker, because we want to do anatomic staging, but we also need to do tumor biology staging, molecular staging, and understand, if we are affecting the micrometastatic disease, that stuff that we can't see, or if we have an aggressive tumor biology despite a very, favorable CT scan, and somebody who's just not going to benefit from resection. So it'll be a combination. What you mentioned about MRI is interesting. I'm going to read a little bit about that because, the fundamental issue with CT scan is that you really don't see that you're failing until it's too late, until you see a metastatic lesion.
Okay, I mean, we're actually over time now. So I think if everyone's okay, we'll probably bring the meeting to a close. Thanks, everyone. Thanks to Chris Wadsworth. Thanks to Heidi, Sharon, and Chris Wolfgang for being our panelists.
Thank you.
Stein is gone now. He's my partner in crime. We had 108 attendees this evening, so that was quite nice. Not quite our personal best, but hopefully more of you will log in on a regular basis. We have our next HPV webinar on the 13th of April, 7 p.m. London time. If I share my screen, it's, oh, no. Can you see that? No. Have I lost you guys? Sorry.
Yeah, we can see that.
What can you see?
I can see.
Yeah, we can see the advertisement.
Oh, great, great. So this is the this is the 13th of April, the next HPV TUGS webinar. So this is going to be on vascular approaches. So I think, Chris Wolfgang, we need you to attend that for your comments.
I'd love to. Love to.
We've got panelists, Elena Ranglova from Sweden, Professor David Chang from Glasgow, and then the moderators will be my partner in crime, Stein, Dutchman, and Nida Amini, who's, I think she's in the audience, a rising star in surgical oncology. And so and that brings us to an end. Thank you, everyone, for attending today.
Thank you.
Have a good evening.
Bye.